Well, hello, Renee. We're back for another episode. I'm excited for this conversation. How have you been doing?
Hey, I'm doing great. We got a lot to talk about today.
We do. It's going to be a busy day. And you know what? My phone has been acting up, and I realized it's from spring break a few weeks ago. I can't mute it because the sand is
Oh,
stuck in my phone. And so I can't get the sand out of my phone. I know it's
oops,
horrible.
that's really bad. Well, I have a story I can share about that too. So, if anybody that knows me, I like to spam and block numbers. I'm really, really good at it. Well, there's two-factor identifications on my work laptop, and guess what I did? Spam blocked both numbers, so I would
Uh,
not get any of the notifications to get into my work phone. I had to reach out to IT and be like, okay, what number might that come from? Because maybe I got a little overzealous with the spam block. So, you know, phone issues today. Well, today we're going to be talking about residential services. If you've been following along, we're kind of in the middle of our deep dive into what services should be because we went through that what was a 30,000 foot level kind of overview of what a service should look like. And today we're going to do that deeper dive into residential services. So we were past talking about outpatient and somebody needs a little bit more. And I'm excited because there's just so many topics we could talk about today. So Jason, which type of residential services do you think we're going to cover in today's episode?
Well, first we should just kind of unpack the word residential, right? Because residential sounds so, I don't know, it just kind of has its own aura that comes with saying the word residential. And what are we talking about? We're talking about when folks need some place to go for a duration of time so that they can have a greater support that they can get in their own home, right? And so there's nothing bad about residential or those types of services. They're very needed, and everyone doesn't always need a hospital. And so I think this is why we miss the conversation sometimes, and the terminology kind of, in the business as we talk about is residential, right? It's that scope of services that are below, acute care, subacute care, but greater than what someone can get in their own home.
Yeah. And I think to your point, there's some stigma and some negative connotation to it because to be fair, our country for a while, we just stuck people places. And so that's that whole asylum movement came from just removing people out of sight, out of mind that needed what, couldn't be in the community and things like that. So there still kind of is a rub about residential. But to your point, sometimes the crisis that you're in is big enough that you need some time away. And maybe being at home with the three cats and the two dogs and the two kids is just more than you can do in that season, and you need to focus on your own physical health. There could be physical health issues in addition to mental health going on, so maybe you need really to be at a location that could have that wraparound of more care. Maybe it's a stabilization of medication and you want to make sure that you're healthy and able to tolerate the medication, and you may not be able to do that at home with all the extra going on. So you're right, residential is really an important piece. And so we're going to talk today about what are kind of different kinds. So there's residential, we talk a little bit about that when we talked about the crisis episode. There's a very short-term residential that you can do, but today we're going to talk even more longer than that. So more like thinking about what is residential for on the substance abuse side. This has been used as a tool for a long time. And then talk about for children. There's one in Iowa specifically called PMIC, was a Psychiatric Medical Institution for Children, which is something that's unique to Iowa, based on another acronym that's escaping me at the moment. That is a federal level. We'll come up with that one in a minute. It's off the tip of my tongue. But different places across the country have these levels of care. And then I don't know if we're diving into shelter, but we could also sort of touch base on how shelter, when you come through the children's movement and you look at kids that need care, sometimes it's different. And it's not just a shelter. We're talking about residential with services.
You brought up something about how long is the services we're talking about. And so unfortunately, I think it's important that we point out that you talk about substance abuse. And I know substance abuse specifically, we kind of got to this 30-day programs, right? You hear about that a lot. People go to a 30-day program. And this is one of the areas where residential is important, right? It's important to get away from the friends, the people you used with, to sober up, to get clear, right? And then start to work on recovery, right? That's the goal. When you're treating addiction. Unfortunately, the length of stays really came from insurance dictating it over the course of the last several decades, and has nothing to do with what you need and what's best for you and your health and your behavioral health. And so I want to point out that when we talk about all of these levels of care, it's dictated by rules and insurance companies. I just read the most recent, some legislation came out here recently in the state we're in, Renee. And you talked about that PMIC level of care, the Psychiatric Medical Institution for Children. Again, that's dictated in the code as to how many days a child will be there initially, and then every 30 days based upon insurance doing a review. Not, and that's supposed to be based on clinical need, but we all know, right? We have different perspectives on why people are there and what the cost is going to be. And so I think it's really important we acknowledge that as we go forward.
Yeah. I just want to remind people that maybe you are anti-insurance and anti-length of stay, and hey, that's cool. But when I first came out of college working, and this is in the way back machine, I lived in New Mexico at the time, and they were a pre-managed care state. And I literally worked in a facility. It was called Mesilla Valley Hospital down in Las Cruces, New Mexico. And you had no length of stay. So literally children would be dropped off and left there. And forever, I suppose. And they would just be raised up in that system. And I remember off top of mind, several children who were there a very, very long time. And the more complicated their needs were, their parents really just didn't know how to parent them. And so it became sort of wards of the state and got left in this private hospital. And so although we don't like insurance sometimes, and we think that, oh, it's swung too far the other direction with the pendulum swing and people need more care, more time, there was a time where people just really were left and no care was really looked at, no necessarily progress measurements, whether he was getting better or not, or that was the best location. And so I see the point of having the 30-day checks to make sure that there really is progress being made and it is for the best. But I also know now we feel like it's swung to the other side and there's just not enough placement for enough kids. So it's a tough conversation, but you're right. Insurance really does drive this. Why don't you define some of the substance use disorder levels of care, like in residential? What are we talking about here? I know crisis we've talked a little bit about, but what else is in that substance use levels of care that you wanted to talk about today?
Yeah, I mean, so, generally we would kind of look at ASAM, right? Those clinically managed medium intensity residential services. And oddly, we're right in between ASAM 3 and ASAM 4. So this is really exciting, right? So, just as we're having this conversation, there's newer definitions coming out to clarify this, to help us better understand what the need is so that clinically we can better approach these situations and match people with the right level of care at the right time for the right need, right? And so as we think about those clinical managed high intensity, medium intensity, and low intensity programs, and generally they're defined within each state. Most states follow ASAM criteria, right? And so if you don't know what ASAM is, you can certainly Google that. There's great information out there to help you to understand that, right? But really what that defines is how many hours of treatment you get per week, right? So at a low intensity residential program, it's 5 hours of treatment. That level 2 medium intensity is 30 hours of treatment. And high intensity is 50 hours, right? And so basically that's how many groups, individual sessions, all those types of things you're going to go to for the care that you get. And that's similar as well when we look at behavioral health programs, right? I know we're focusing on substance use disorder, but as we look at other programs, right, the intensity is based upon how much treatment you get during your stay throughout the week.
Yeah. And I know that when we think about that too, it's that seems like it's so maybe not enough hours. So if you're there living and you're only getting 5 hours a week, and that seems like there's nothing else going on, but there's really more to it than that in those residential environments. I know when I was in the psych unit with our milieu is what they call it. But really that it is the community in which people are living that is trying to bring forth pro-social involvement, positive peer support. And so it's not just about the number of hours you're sitting in front of a clinician. There is other things going on that unit that is helping people get the rest that they need for one. And then also, having supports of others who may be at different stages, making more progress than them, who can share life and life stories. And then also knowing that they're not alone. We'd also have many, many times when a person would come into residential, they're thinking they're the only ones that need that level of care or the only ones struggling in that capacity. And then when they get there, they realize there's other people really a lot like them who are struggling too. And so then they're not alone, and then they can talk about those things. So really that residential is really that wraparound. And then the other piece, if think about this, if you're like in crisis and just exhausted, like I said, you had the cats, the dogs and everything at home and you're there, somebody's caring for you for that time, right? They're bringing you their food. They're They're, reducing the number of decisions you have to make, just making life simple so that you can focus on one thing, and that is getting healed and getting focused on what needs to happen. And so there's really is some great stuff that's happening there. Now, on the mental health side, Jason, there's all the levels of care in residential, and these get complicated because there's all kinds of acronyms in here, but I know you're going to help spell them out today. But what on the mental health side, what have you seen for residential levels of care?
Yeah, and so this becomes acronym soup, right? Because we'll start throwing out terms like PMI, RCF PMI. It just kind of goes on and on. Right? We can talk about all these different things, right? And so I might need you to help me with some of these as we go through it. I'm looking at the list right now. I'm like, it becomes difficult, and we do this all the time. And I still have to look at a cheat sheet sometimes to recognize what the acronyms are. And so, part of it is addressing multi-occurring conditions, right? And so whether we're talking about intellectual disabilities, developmental disabilities, or SUD, all of those things multi-occur together with some individuals. And so sometimes it's really hard for our systems to respond to a complicated person who has lots of different needs. And so some of the programs that have been designed and some of these levels of care that we're talking about now are specific to populations that may have some multi-occurring conditions. So when I think about IRSH, which is intensive, go ahead, Renee, help me out.
Intensive residential service homes.
Thank you very much. Those are designed around what population?
So those were designed with it was considered complex needs, but complex needs were including potentially some intellectual disabilities or developmental disabilities, or even some physical disabilities, in addition to mental health, in addition to maybe substance use. And so kind of in that combo space. And at the time in the state of Iowa, the idea was they could track the number of people that were continually being in the hospital. And I can't remember what the continual number was, but it was a high number of like 6 admissions in a year, maybe 10 admissions in the year. It was a high number. And those people, there was about 120 of them in our state of 3.5 million people. We only had about 120 of those folks, but they were really struggling with having housing, having, ongoing supports for maybe job or employment, or even disability funding, or staying on their insurance, or staying with Medicaid, just folks that really fall through the cracks, that were struggling across the board to a point where they'd be maybe removed from an institution or a facility for their behavior and then not be welcomed back, but yet not really need to be in a hospital and not really need to be there, but needed more supports. And so the concept was to build homes, smaller homes of maybe 3, 4, 5 people. And we have this idea before, but at a much more high intensity of services, to Jason's point, with more people coming in, more hours on the clock per day, to kind of wrap around folks to see if they could be successful at home. Because believe it or not, most people want to be at home if they can be. They don't really want to be at a place. And that's very different than the way the system was built. And so this was the idea of helping them kind of find more of a forever home. One of our advocate friends, Leslie Carpenter, that I hope we have on here in a couple of months to talk, she talks about housing that heals. That's her big topic that she really pushes. And housing that heals is a big movement across the country, where people need to have housing that is supportive of folks that have those complex needs, but housing that they just don't lose when maybe they forget to pay the bill, or they get in trouble for something, or break a rule in the housing. And so that's sort of what the IRSH homes were designed to be.
Yeah, and one key element I think you touched upon there is that it's about the space, right? So this is generally 4 people or less, but thinking about those community-based homes where people can live. And because homelessness becomes a huge issue when we're talking about these types of things, of maintaining a household through all of these transitions that someone goes through typically as they find their own recovery and have different relapses throughout their life, which is expected. And so there's going to be periods when people get better, and there's going to be periods when people get worse. And so to be able to sustain someone through all of those times takes a lot of support. And so one of the largest challenges, when we talk to providers, we talk to family members, is about maintaining a place to be, right? You can wrap supports around someone if they have a place to be. If they don't have a place to be, it's much harder to wrap the supports and assist someone.
Right. So let's back up and go through some of this alphabet soup. I know one thing we talked about was RCFs, which are residential care facilities. Now, residential care facilities on face value is anybody And this could be disability driven, this could be mental health driven, and it's just a level of care that is people need more supports. And so really predominantly in our system, the disability side weighs heavier in the number of beds in this space, but this could be anybody. There's not a ton of supports in that level of care as far as in the home. There might be staff that does like the types of chores that need help for daily living. There's another acronym I can't think of, but basically the daily living chores. So they might come in, maybe they need help, getting their groceries or paying their bills, or they need help, making meals, or they need help with their bathing or making their medications, that kind of stuff. So residential care facilities can be that. They used to be in our state really large facilities, but now they are below 16 beds because we want to make sure that Medicaid is eligible within those facilities. And that's an exclusion from the federal government called the Institute of Mental Disease, or IMD exclusion. And there's a lot of fights about that at Congress. But for now, the rule is that Medicaid can't be used in a facility over 16 beds for anybody for residential. So you keep hearing us talking about less than 16 beds. Well, that's because that's what the federal government has told us in order to use all of the federal funding. And so if that ever changes, which there's talks about it all the time at Congress that it might, then bed numbers may change and move. But we used to have really big, think of your like county home. Lots of people always had a county home. County homes could be kind of like a nursing home, but they could be like a care facility. That's what it kind of used to be, and really not there anymore because the state didn't want to pay for those full time. So that's the residential care facility. The next one, we talk about an ICF, which is an intermediate care facility. We have some of those as well. And then what Jason said was an intermediate care facility for persons with mental illness, or ICF PMI. Lots of acronyms, but in that level of care, intermediate care facilities really can be more, they are created more for the folks that are over age 65, that older nursing home type population. There are some exceptions, and you can get a few beds under 65, but not many, because most of them are at that higher level of care for older persons. Now, these persons might be folks that have had sex crimes. They might have had violent tendencies and been removed from locations. They might have physical needs, like maybe a ventilator, and need a very high level of care because of physical needs plus mental health. So the PMI part is the plus mental health, persons with mental illness. The intermediate care facility is for all kinds of different folks. But once you get intermediate care level plus mental health, then you have ICF PMI. So sorry for all the acronyms today, but there's tons and tons and tons of these when we're talking about levels of care. And it makes it kind of complicated for people to know, how do I access them? How do you get one? And all of those types of things. But was there any of those in that big list we just forgotten?
I'm exhausted just listening to the list. And it makes me want to ask a question about effectiveness, right? We always talk about data. And so we just talked about all these different things, which kind of feels like we've been throwing Jello against a wall for a whole bunch of years and just keep adding to the list of acronyms.
Right.
Do any of these really work, Renee? Like, what does the research tell us about residential care?
Well, when you're going to have to answer this one if you found newer information, because when we were back in redesigning the system back in the early 2010s, late 2000, there really wasn't. And so when we created the new list of core services at that time, which is changing again today, but at that time, one of the things left off the list was residential care facilities. Because two things. One, there was no bed cap in the state at all. So you could have as many of these beds as you wanted. And there was absolutely no research or information or data to show they were effective at all. They kind of became just sort of transitional housing. And so we decided and made a lot of people mad that wasn't going to be a core service. So now we didn't say you had to stop doing it, but what it did say is, hey, we're going to focus on these things that we know are evidence-based or have promising practices that show effectiveness. And if you want to continue doing that, you're going to have to pay for that yourself, because we want you to focus on things that really do have some backing. So the IRSH homes are in the list of things that were considered evidence-based and were considered promising practices. And so they were put in place of just a residential care with just your daily living type of things happening. But more than that, we also had some things like that were kind of like adult daycare centers. They were called something different, and I don't remember what they were called, but basically people were dropped off to just be sort of watched for the day, but there really wasn't any programming or any kind of treatment happening during the day. It really was like watching movies, take them to out to the store or whatever, and it was more of a social type of thing, which is all great. But Medicaid is like, that's not what we pay for. We pay for medical services. These are not medical services. And so, not that you don't need maybe adult daycare type places to go, because you do. And it's really important that the cognitive decline level of people that have dementia and such, really important. But you have to have it for what it's for, right? And it has to be showing that there's reasonings for it. And back then, there just wasn't some of that data. So I know there is some data showing some of these things are effective, which is why they still exist. But at the level of which we had them, it was sort of just as we deinstitutionalized, which is a huge word, but once we moved away from the big state hospitals into the community, we basically just built different buildings with lots of people in them and called them something different. And it was still kind of the same treatment, and which wasn't considered good by the government. So we had to make changes. And so that's sort of what I know about that. How about on the substance abuse side? Jason, did you see the same thing?
Yeah, I think the nuance that's really important here to highlight is thinking about, you just don't take someone out of their community and make things better. The supports have to continue after that course of treatment, right? And so that's where like the IRSH homes, they're a promising practice because you're wrapping services around where the person lives.
Right.
Their long-term house. It's not transitional housing. That's their permanent housing option, right? And so I think that that's the big difference as we start to separate these out. You don't send someone to Florida for addiction treatment and then bring them home with no aftercare plan and no services in place, and expect that everything's going to be okay. That's not how this works.
Right.
And unfortunately, we still have a lot of that in our system, right? You go to the glam treatment facility on the beach somewhere for 30 or 45 days, and then you come back home and you're not connected to all of the supports you need to transition back and be successful. And so that happens in substance abuse. It also happens with kids, right? So we talk about these PMIC facilities or other type of residential care with kids, where kids are plucked out of their home and put in a facility, which kind of goes back to that ideas that we have of the past, right? You take someone away from things, but then you don't have a solid transition plan of how do you support someone when they come back home in their forever home, transitioning forward. And so I think that's where, and we'll link a few articles that basically say that if you have best practices going on and you have a clear transition plan and supports after a placement, that can be very successful. If you don't, then there's really no data to support that it makes any difference at all.
Right. And as we're talking about PMIC, just for those that are listening, this is for children under the age of 21. And it used to be a pretty unlimited number of days. Even in my lifetime, even in my work in the state, it was a long time stay. And it depended on the facility as to how long people stayed. And again, kind of like my story from before, when in the 90s, back in mental health days when I was in residential, it was kind of like that. They were sort of untouchable for a long time, kind of carved out, if you will, of any insurance in our state, where people just stayed forever. And again, to Jason's point, that wasn't what's best for people. First of all, it doesn't matter how long you remove a child from a family, they want their family. And we did foster care for a while, and it did not matter what happened, how bad the parent was, how bad the person was harmed by the parent. It did not matter. They wanted the bear parent. And that is what all research shows. So for us to remove people completely from their family and expect that to be somehow better is not a good idea, because even at the time they turn 18, they're going back toward their family. That's what we're all built to be, and we're going to go back and figure it out. And then numerous times with my foster kids later, they'd say, I thought you were not telling me the truth, and I went and tried and it didn't work, after they turned 18, and then say that it really isn't good. I really shouldn't be around those people. But they needed to kind of figure that out for themselves. And so by just removing kids, you're not working on the family system. I'm much more of a system type person. So PMIC, when it's done very well, works with family, working intensely with the family while working intensely with the child, with the goal of reunification and getting that child back, because that's where the child wants to be. And so making sure we think about PMIC, it's a great program, but it's not meant for forever. And it has been a huge transition. There's a lot of people in our state that really struggled as the numbers of days sort of declined. And so it's important that our listeners know what it is. So what are some of the links that you're going to have for folks today in our show notes if they want to get more information?
Yeah, absolutely. And so I have a couple links from the National Library of Medicine that highlight the effectiveness of residential treatment, specific substance use disorders, kind of a systematic review of a lot of the other research that's been done out there. And so I kind of like those recap articles, right? Where you
Yeah.
kind of just read one summary and kind of get a sense of what is all the research out there telling us. So I think that's going to be a great one to take a quick click on so you can think about that yourself. And I got another one from Mental Health America, just about how community care impacts mental health. And it also helps us to kind of go through what some of these, all these different types of programs are, and helps us when we need to talk about it with other people. So I think both of those things are really helpful resources as if you find yourself needing to have conversations with folks or advocating or trying to understand what the difference between some of these different levels of care really is.
Yeah, that's really good. I know, Jason, you have a story for us about some things that you've seen that have been done in some of these more independent residential spaces to help people become more independent and to actually embrace their home as home. You want to share about that?
Yeah, I think kind of to put us back on a positive note, right? Like where are
Mm-hmm.
we going with all of these different types of things, and what does the future look like? And so I've been lucky enough to be traveling around, and I'm kind of take a page out of the intellectual disability, developmental disability playbook. Historically, folks lived in group home type settings with staff who would come in, and sometimes the way that's funded is staff. There's a plan, and the staff have to go in for how many ever hours a day that the plan dictates. And so in rural areas, there's huge staffing issues, right? And sometimes the staff go in and the person they're serving may be taking a nap, right? And the staff just has to sit there because that's what they're funded to do, right? It's not, the staff are needed during meal times or busier times, right? But sometimes they're there just because they have to be there a quota of hours because the plan says they have to be there. And that doesn't make any sense, right? So we talk about inefficiencies in the system. You're using the wrong resources at the wrong time. And so one provider, which was really innovative, said, well, you know what? I think we can do better with this. We're going to use smart home technology. We're going to use cameras and motion sensors, automatic lights, and they made a completely smart home with apps. And the individuals could contact a staff by pushing one button on their phone, and everything's fully connected. And they were able to decrease the number of hours staff were in the home because they could track when the person was up or when they were sleeping, when it was nap time.
Mm-hmm.
And they only sent people in during those busy times, meal times, transition times when staff are needed, right? And so they decreased the staff time by 50%. And they took some individuals that had to be in a group setting and they became so independent because the technology supported them so much, they can now live by themselves in their own home alone, which
Awesome.
is awesome for the folks because it's teaching independence. Many people said they can never live independently. They can never live in an apartment by themselves. And now using the technology and the supports that technology provides, the organization, provides the tech support. They're monitoring folks 24 hours a day, right?
Mhm.
For safety. And as we think about the future, we can do that with heart rate monitors. We can do so much with health. And to me, it was so exciting because they didn't realize it was going to create a greater independence. They thought it was going to decrease staff time. They thought it was going to increase efficiencies for the organization. And then lo and behold, they discovered we're making people more independent and they're having fuller, richer lives because of the technology we're using. And so to me, that was such a great story
Yeah.
because you could see firsthand of how much doing some of these things differently can impact people's lives. And that wasn't the original intention. It kind of happened by accident. But I think about other technology. See, I get excited about technology. Like I need a new phone now, right? We've had apps, especially around addiction, where it can track your movements if you get
Mhm.
close to a place where you used or a bar, or we kind of talked about a casino, right? If you have a
Mhm.
gambling issue, then that could contact your family or your treatment provider, right? We haven't really opened the door to utilizing these greatly, right? The same thing as wearables and health, right? We haven't really gotten there where when I walk into the doctor, they're looking at my average, heart rate and all the different things that my Apple Watch is collecting on me every day, right? I have tons of health data on my person every day, and I'm not sharing that as well as I could with my medical, my doctor, my PCP. And so I think we're on the verge of being able to do all of those things. I think it has a huge impact on the population we're talking about today.
Yeah, that's really great. It's pretty exciting to hear where we could go in the future. And, we always talk about the fact that workforce is not going to just reinvent itself. And so all the things that we can do in this space that can make people more independent and keep them healthy without staff is going to be huge for the future. So it's really, really exciting. Today, we're going to talk about the recovering politician self-care policy of the week. And, I started thinking about things we talked about last time about ways to increase self-care. And I was talking about kind of creating, thinking about what needs to happen. And in my life, sometimes I just need to delegate. For me, I realize there are things and people around me that can do stuff so much better, so much faster than I can. I'll give you an example. I can write a slide deck for a PowerPoint presentation. I can do that. But I'm not good at it. And there's lots of typos in it. And Jason and I both have an affinity for capitalizing words that shouldn't be capitalized. I realize now that I've hung out with him too long that I do it too. And so we have a lot of proofing that has to be done afterwards, or you're standing in front of a big room and you're like, oh, now I see the typo in front of lots of people. But there are people out there that can do that so quickly and they're so efficient at it. And so when I stop to think, hey, maybe this really isn't something that I should do, but somebody that around me that's in my space that one loves to do it, two is great at it and would be thrilled to help me, I should ask. And so in your self-care space, if you're thinking, man, there's just too much to do and not enough of me to go around, sometimes you have to sit back and think, okay, who else should I be talking to? Because I'm telling you, it is always, every time I do this, I am just flat amazed at how fast, efficient, and quick somebody else is at something that would have taken me 3, 4, 5 times longer. And they love to do it and are very grateful for the opportunity. So it just reminds myself over and over and over, just delegate certain things that's not meant for you. It's not, I don't know, this whole day and age of us doing everything and being the self-made person is just for the birds. So part of self-care means, you know what, you're better at this than I am. And my husband and I, we think about that too. There's things that I'm better at. There's things that he's better at. And if we could just work together as a partnership, it just makes that better. So Jason, have you ever saw anything like that for delegation and where you're trying to do it yourself and it could have been done by somebody else a whole lot easier?
Every day, and I think sometimes it's just hard to let go. And so part of it is just, preparing yourself that sometimes you just have to let go and hold your breath and let it go. And, sometimes that can be hard. We have virtual assistants that I lean on to do a lot of stuff. And there's sometimes I'm like, wait a minute, I still haven't seen that email. And so right now there's one email I'm waiting to go out for a meeting next week. And I'm like, we need to make sure that goes out, but I'm not doing it, right? It's there's other people who could do that better. But it doesn't mean that I'm still not paying attention, right? And so that's part of letting go. It's part of focusing in on what we can do best. And, that's part of why I do what I do today is because I can focus in on the areas that I can be most effective because that's what's best for me, and I can let that other stuff go. But sometimes it's hard to let it go. And so I think that's the key to leadership. And that's the key to, as we talk to other executives and as we do coaching, is we think about how do we help people to get comfortable staying in their lane and letting go of that other stuff.
Yeah. Well, thanks for everybody for joining us today. Today, we really talked and did a deep dive into residential levels of care. And I know there was a ton of acronyms in this one. And so we have a lot of great things for you in the show notes. You could go back and look at, well, what is a residential care facility or an RCF? Or what is an intermediate care facility for persons with mental illness or that ICF PMI and all the other acronyms like a PMIC. And you're thinking, what in the world are all of those things? Well, we gave you some great notes that you could dive into, like Jason said, kind of that higher level research overlook that you could say, oh, this is what's going on in residential. Join us again next time, because next time we're going to be focusing on the topic of acute services, including state hospitals and mental health institutions. See you then, everybody.